Okay, good afternoon once again. So we'll be starting our sessions. May I introduce myself? My name is Harriet Hiera. I'm a physician and a faculty in internal medicine MUHAS. I'll be chairing this session. So to start with the first, may I humbly welcome Dr. Mwanada Kilima, who will give a talk on feasibility of contactless remote patient monitoring technology in Tanzania, a representative case of Muhimbili National Hospital. Dr. Mwanahada, she's a practicing pulmonologist from Muhimbili and honorary lecturer from Muhimbili. Dr. Mwanahada, please welcome.
Keep it in presenter. We have online now. Link. Yeah. It's okay. Hello, everyone. Good afternoon. It's an honor to be here. And first of all, I would like to thank and acknowledge my co-authors for this presentation. This is not a research paper per se. It's not a presentation for research work. Rather, it's a product of a feasibility study that we did at Muhimbili National Hospital, which includes some research or literature review. So we are presenting feasibility of contactless remote patient monitoring technology in the country with example of our hospital, Muhimbili National Hospital. And for introduction, I think I'm facing a technical issue. The entire thing is not showing. So what is remote patient monitoring or contactless remote patient monitoring? That's supposed to be there here.
Presentation. Presentation.
Okay, so my apologies. This slide is defaulted. There's a part which is not showing. Basically, contactless remote patient monitoring involves what we call ballistography technology, whereby a patient lies on the bed, and the picture was showing that. Unfortunately, some technical thing happened. And what happens is the patient lies on the bed. There's a sensor beneath. Okay, we call them piezoelectric sensors, which can sense the vibrations of the cardio and respiratory movement and every other vital activity in the body. And that is transformed into the cloud. And then the nurse or any other medical personnel can see that on their screen. This technology also gives early warning system for any derangement in the vital parameters. So in brief, this is what the technology is all about. And it is meant to reduce workload for nurses, but also save lives. It's very important that we have ICU-like environment in the ward, whereby we have capability of monitoring all patients in the ward the same way that we could do in ICU without having to touch the patient. So this is the basis. And as you can see on the sketch, you have multiple beds which are connected to one monitor where the nurse can see everything that is happening to the patient. And best part is that it can give you an early warning system. For example, when the saturation is low, the nurse can tell that bed number 16 is desaturating, and they can run to the patient and save a life. Or the blood pressure is on the higher side, and so forth. So this is like having ICU environment in the ward setting. And as I said before, it can give early warning, as you can see there, and the warning can either be in any of the vital parameters, and after that, of course, that needs to be attended. I know that in some of our health facilities, the nurses and other healthcare workers may not attend to an emergency in time because of many reasons, negligence, being too busy, and so forth. But this system is in such that if there is an alarm, the person has to attend, because that alarm will never stop until you go to the bedside. And because of the importance of this technology, this was introduced to our hospital at the end of the year 2022, and we decided to do a feasibility study. And this was an initiative of our director, Professor Mohamed Janabi. He formed a technical committee because he thought it was a very important thing to adopt. And so we did, first of all, a pilot study within the hospital for that long period of around 2 months. And after that, we formed a committee and we started to review more on this technology. And we had our TORs, we had our methods, which included virtual meetings, physical meetings with different stakeholders, including health economist, director of ICT from different areas. We consulted the e-government, TMDA, biomedical personnel, and also the manufacturers of this product. And we also had discussions with hospitals within the country that had already been utilizing the technology, because a pilot had also been done at Hindu Mandal, at Saifi, at JKCI. So we also consulted those. But we also had to visit the facility, which are manufacturers, producers, and also marketers of this. And we had a lengthy look at what is happening with it. We were exposed to the environment, to the technology, to the different things, including challenges and technical know-how. We also visited a number of hospitals in India, and we will show you the findings. In Tanzania, at JKCI, they are already utilizing this in VIP and HDU, and the director himself is part of the technical team. And himself, as well as the director of nursing and other nurses in charge, are all part of the technical team. And they have a very big, if you go to JKCI today, first floor, there's a very big LED screen that displays all these vital parameters and the alarms which come on the first floor. And the experience we got from them is that DOSE is excellent in vital monitoring and also alerts, because in cardiology setup, this is very much required. So this is the feedback we got. But they also say they needed more training and technical support. And among the hospitals we visited also includes some outside the country. That one of them is Ramaya Memorial Hospital, a very big hospital that offers not tertiary, but quaternary care. Quaternary care means they deal with transplants, they deal with such a level of care. So multi-organ transplant, lung, heart, and so forth. So again, there are 87 beds which are connected in their hospital, and of course they charge the service. As well, we also had a discussion with the director of Bellevue Hospital in Calcutta, and also we got some positive feedback. And at the moment, even the nurses are actually demanding that this is reducing our work. We want more of this. So please connect us to DOSE, because it's a lot more time-consuming, less time-consuming and less labor-intensive when we have all beds connected. Apollo Hospital, we all know about this. They have 12,000 beds all over India. They have 74 hospitals in the country, in India, and they utilize this technology. And their center is at Jubilee Hills, Hyderabad. And generally, from the local and international exposure that we got, is that the technology offer is simple to use, and it has led to less medication errors, and because more time is spent for attending on medicines rather than vitals. So this is statements from the nurses themselves. It is easy, it offers easy monitoring and time saving, and you can make timely decisions with it. These are some of the feedback we got from the users. These are the users of this technology from the different parts of the country and outside that we got. And the best part is that the nurse supervisor, the nurse supervisors, the nurse superintendent, they were happy about this because they could monitor every single hospital bed from their office. They don't have to do rounds to see who is sleeping, who is doing what. So they can tell that in ward number 5, there's an alarm which is not attended. And the nurse superintendent can monitor the whole hospital from their office. The results from the pilot that was conducted at Muhimbili National Hospital and also Seifi Hospital, we did a comparison of that. And finally, there was accuracy of 99.3% for all the vital parameters. And the same with Seifi. Seifi had an accuracy for this particular technology was 98.4%. And we also, in our literature review and such, we also found out that this product or device is accredited by US FDA and all major accreditation bodies regarding medical devices and also technology, medical technology within and outside India. And that one includes US FDA. But there are a multitude of awards that have been received, and multiple research papers have been presented. And at the end of the session, if any of you is interested, I have some of them I can share with you. So this is backed by research as well. So publications are also available. We went ahead and investigated on data security because this is IT-based technology. So data security and ownership, and we were reassured by e-government and other governing bodies for ICT, medical related data and so forth, that this data can be hosted within our local Tanzanian cloud, and there's no problem about that. And our health economists also did research, and this is part of the research that was done in India, giving positive feedback on reduction of workload for medical staff for at least 2.5 hours per day. So a nurse would save 2.5 hours per day if they use RPM. RPM is remote patient monitoring and early warning system than the usual way of measuring blood pressures for every patient, for every bed, for example. There's improved patient care, and also hospital bed utilization is also optimized because instead of having a patient stay in ICU for 10 days, you can give them a discharge from ICU, and when they are in the ward, they are also monitored, so you're not worried. The same way, a patient has come from surgery, for example, they have done a knee replacement or maybe a fracture repair. Perhaps they have a complication, they need to go to ICU, but in most cases, post-op patients, most of them because of anesthesia and so forth, they need monitoring. Instead of occupying ICU beds, we are changing the ward beds and HDUs into ICU. So even for immediate post-op monitoring, this is highly useful. So research has been done on that area as well. Our own health economists gave an analysis that this is also profitable. If anyone wants to make it profitable, they can make it so. Of course, we are a public hospital. We are not advertising this or anything. But if you have to charge a patient per bed because they are using ICU care in the ward, then the minimum you can charge them is around 19,000 to 20,000 per day for bed. And I know that HDU, we charge around 50,000 for NHIF patients. So this is even half the price. So if you want to talk economically, this is also, it gives you high profitability if you want to charge patients. But for service, the benefits are as I mentioned. So analysis has been made also in terms of economics. So finally, after a literature review, thorough visit, and the analysis that we made, we came up with recommendations, and we believe they apply to other hospitals in the country as well, because we did a countrywide or a country-based approach in terms of laws governing ICT in the country, in terms of feasibility in a ward environment, which is not so different between Muhimbili, KSMC, and Beira Referral, for example. So we strongly believe this can be applied in the country wide. So conclusion and recommendation is that contactless, remote patient monitoring and early warning system will give rise to reduction in workload for our nurses, optimize utilization of human resource, improved quality of care for our patients, reduction in ICU bed occupancy, and it's also a reliable database for research. One thing I forgot to mention is that you can extract data for the way you want it. It's customized. If you want vitals for a period of 1 month, you can get them. If you're passing rounds and you want the vital parameters for the past 24 hours that you are not around, you can get them. So you don't need to print anything. Everything is on your phone or laptop or a tablet as you wish. So this is a digital way of monitoring our patients. We have found out that it is feasible at Muhimbili National Hospital, and we believe it's the same for the entire country, as it is evidenced by literature, and it is backed by research, as well as accreditation by major governing bodies in the world. And at our hospital, we recommended that we start with HDUs, because that's where we want more monitoring than just next to ICU. But of course, the future plan is to make it hospital-wide, everywhere, if possible. But we also recommend more training, especially from the feedback we got from different users within and outside the country. So doctors, biomedicals, and nurses need to be empowered more. And also the SOPs for the use should be in place. The server should be hosted in the country. It's a cloud-based technology. As recommended by e-government, the server should be hosted within the country, and data ownership should be 100% hospital-made. So it's not that the company owns data, and this should be integrated into the hospital system, the HMIS, which is also possible. We call upon collaborative research between the company and the respective hospital users, because we have found out that there's a lot of information that we could get from this simple device. Asanteni.
Thank you so much, Dr. Mwanada Kilima, for a technological talk, giving insight on improving our patients' care, but also in an administrative way. So we are going to have a second talk, and this comes from Dr. Gertrude Mollel. Dr. Gertrude Mollel is a senior resident in pediatrics and child health, doing her residence at MUHAS. She'll be sharing with us a talk on accuracy of a smartphone application for blood pressure estimation in Bangladesh, South Africa, and Tanzania. Welcome, Dr. Mollel.
Good afternoon. So my name, as introduced by Dr. Harriet, I'm Gertrude, and I stand before you as a representative from Ifakara Health Institute, but as she correctly said, I'm also a resident at MUHAS. So I'm here to present a team of research scientists from Ifakara Health Institute, John Hopkins Research Institute that's stationed in Bangladesh, and South African Medical Research Council on the collaborative work that we did on accuracy of smartphone application for blood pressure estimation in Bangladesh, Tanzania, and South Africa. And this work was published in Nature earlier this year for further details. So this being the third day of this conference, I don't think I need to emphasize anymore how much NCDs are growing. The burden is growing globally and in sub-Saharan Africa, and hypertension being among the major NCDs that we're dealing with. But then we know 70% of people living with hypertension reside in lower middle income setting, and almost half of these are unaware of their condition. And not only in general adult population, but we also know that hypertension disorders of pregnancy carry substantial morbidity and the risk of mortality for both the pregnant woman and then the unborn fetus. And so innovations that have potential to leapfrog and enable accurate BP estimation are very critical for diagnosis. And the figure here presents the growing burden. This presents the burden of hypertension from 1990 over a decade period to 2019. And in red is the number of hypertension cases in millions that remain undiagnosed. The bigger pain on that will be your right is for global burden, and you'd see the picture is not different if you look at your right on the deep on the right corner where it's representing sub-Saharan Africa, and the picture is the same. The overall burden for hypertension is growing, and majority of our patients remain undiagnosed and hence unaware of their conditions and hence untreated and susceptible to complications. So we looked at an app called OptiBP. So OptiBP, this is a smartphone application that currently runs on Android phones, and it was already defined by the WHO Compendium of Innovative Health Technologies for Lower Resource Settings. And what OptiBP does, it leverages the smartphone camera to record the optical pulse wave derived from the to the fingertips at the blood volume delivered to the fingertip changes. And so to be able to use OptiBP to measure blood pressure, the user has to press their index finger on the smartphone camera for 30 seconds, and that's basically all they need to do. And the algorithm built within the OptiBP app will transform the optical pulse variation during systole and diastole and the waves into raw BP values, and then process this in a calibration reference to estimate the individual's BP. So image shows how it works, basically placing the index finger on the camera, and as the blood pressure or during systole and diastole as the wave changes, it records the optical pulse waves and then calibrates these into individuals' blood pressure. And so the objective of the study was to assess or to validate the accuracy of this app, OptiBP originally, but then we called it CAMBP during research. So CAMBP is basically a research version of OptiBP, and the difference is only that for CAMBP, the provider or the tester was blinded from the readings, but it's basically the same app. And we want it to be done in different environmental condition and demographic profiles. So for Tanzania, the study was conducted in Ifakara. It's a rural setting in southwestern Tanzania among a general population of adults. Same to Bangladesh, it was among general population, but in South Africa, the study was conducted among pregnant women. And we also know the inherent limitation of systematic exclusion of pregnant women from research, unless the research is about the pregnancy itself or the fetus. And this was a cross-sectional multi-site validation study that basically was comparing the standard cuff BP measurement with the OptiBP measurement. And because this is the first time the OptiBP was being used in low-middle income countries, the study was done in two phases. Phase one was to calibrate and assess OptiBP algorithm, so to train the algorithm to LMIC populations and settings. And then phase two to assess or to validate the accuracy of the OptiBP against the curve measurement. And this performance was evaluated against the International Standard of Organizations criteria. So inclusion criteria for Tanzania and Bangladesh, it was among adults 18 to 80 years old. And exclusion was if the blood pressure measured, initially the participant would be measured blood pressure in both arms. And if the difference between the two arms were more than 15 for systolic and more than 10 millimeters of mercury for diastolic, then that was an exclusion criteria. Or also a sick patient with any definition of unstable cardiac condition, for example, myocardial infarction, or patients known to have suffered from pulmonary embolism, arrhythmia, or in heart failure, they were excluded from the study. Or if the patient did not have an index finger for any reason, because that was an important part in order to be able to use the OPTBP. And for Tanzania and Bangladesh, pregnancy was an exclusion criteria. However, it was an inclusion criteria for South Africa, and the age was 18 to 50. Exclusion criteria for South Africa are more or less similar to Tanzania and Bangladesh, with an addition that for participants who had blood pressure above 160/10 and over 110, they were referred for immediate inpatient treatment. So to be able to conclude how OPTBP works against CAF-BP, we need to have a very variable sample. And so there were sampling requirements. The first one being that at least 30% of the participants should be on either gender, so that we can be able to say if OPTBP works for both males and females. But also to be able to say if OPTBP works across a range of measurements, we needed at least 5% of people to have blood pressure ranges below 100, that's hypotension, 100 for systolic and below 60 for diastolic. And then at least 5% to have blood pressure reading above 160 for systolic and above 100 for diastolic, and also 20% to have a high reading of above 140 for systolic and 85 for diastolic. This is to be able to conclude the functioning of the values obtained by OPTBP, of the functioning of the OPTBP across a range of readings, and also both males and females. So the procedures were guided by the ISO criterion, or the International Standard Organization for Standardization Criterion, and also the consensus statement from the Association of Advancement of Medical Instruments, European Society of Hypertension, and together with ISO. And once you obtain, the participant comes, the study was conducted into obtaining BP measurement in 3 rounds. So the first round was just to validate if both left and right blood pressures were not very similar. But also first round of blood pressure measurement was done with the participant at rest. That was block 1 reading, and would have 4 rounds of having CAF BP measurement by 2 different independent nurses who did not know the readings from each other. And then block 2, we had 4 rounds of blood pressure measurement from 2 nurses who did not know the reading from each other. But this was after 2 minutes of exercises that the participant had done. And the participants were given ankle weights, and they were doing flutter kicks for 2 minutes, And this was a descriptive analysis basically for participant characteristics and distribution. But then we had 2 ISO criterion. The first one is that the mean error and standard deviation between the CAM-BP reading or the OPT-BP reading and the corresponding reference value of the CAF should have the mean error of plus or minus 5 with a standard deviation of 8 millimeters of mercury. But also criterion 2 is that for each subject, the average BP measurement was done from the CAF reading and from the CAM-BP reading. How does it differ from the maximum permissible error that was, mean error that was calculated from criterion 1 above? This study was approved by the WHO Ethical Review Committee, but also national review boards from Tanzania, South Africa, and Bangladesh. And blinding was a very important part of this study, so that we cannot say that the researchers, documented CAF-BP reading that are similar to the OPT-BP reading. So we would only be aware of the CAF-BP reading, but we wouldn't be aware of what the CAM-BP reading was recorded. And we obtained around 1,500 valid paired measurements. This is from 153 participants from South Africa, 103 participants from Tanzania, and 95 from Bangladesh. But there were also 1,100 exclusions reading. And 40% of the exclusion were because of nurse reading were differing for more than 4 millimeters of mercury. And 1/3 of exclusion was because of unsuccessful CAM-BP reading. Maybe the optical was poor signals, poor quality signal, or irregular heartbeat. So this basically is a diagrammatic presentation of my previous slide. Allow me to skip it. So looking at the characteristics of the participants from South Africa, majority of the participants were between 36 and 49 or above 30 years old of age. And this being a pregnant population, we assessed hemoglobin and the mean was 12.4. And looking at the trimesters, majority of almost 50% of our participants were above 28 weeks gestational age. And also we had 10% who had preeclampsia with proteinuria. So the readings we're getting, all the validation is like we're getting the gestation age and BP readings. For Tanzania and Bangladesh, there were similar characteristics. Majority of the participants were aged between above 30 years old or above 36 years old. Male to female ratio was also not very different, 40% by almost 60% from each country. And we see we had 13% of participants with systolic blood pressure between 140 and 159, and diastolic 4% had above 100 for Tanzania and 1.6 for Bangladesh. So looking at the ISO criteria, remember ISO criteria 1 was looking at the mean error and standard deviation between the CAMP BP reading and the CAF BP reading, and shouldn't have been more than 5. And all the systolic blood pressure and diastolic blood pressure from all the 3 settings met the ISO criteria for the use of CAMP BP for measurement of blood pressure. And then looking at the criterion 2, where it was about the maximum permissible standard deviation as a function of the error that was calculated in criterion 1, so Bangladesh had a maximum permissible standard error of 6.09, but what was found on the calculation of 6.4. So Bangladesh did not pass for criterion 2, but the rest of the sites, also the readings for CAMP BP and CAF BP passed both criterion 1 and 2. So all sites achieved the ISO criteria for the use of CAMP BP for assessment of systolic blood pressure and diastolic blood pressure for both general population and pregnancy population. And Bangladesh general population fulfilled the criterion 2, but for diastolic, but not for systolic blood pressure. And these findings being the first time being conducted in low middle income country settings, this only adds up to the findings that were already observed when the study was conducted in high income settings in Switzerland. But there is also a need for further algorithm realignment because of the deviation that we observed from Bangladesh. Challenges, there were challenges on recruiting hypertensive participants, and this made Bangladesh not able to achieve the required sampling of 5% hypertensive participants. So in conclusion, OptiBP demonstrated accuracy, and it's valid for both general and pregnant population in measurement of blood pressure, except for ISO criteria number 2 for SBP in Bangladesh. However, with the global penetration of mobile devices and emergence of digital tools in medical care, we think OptiBP stands is a good candidate for further studies for its clinical use, for readily use for early diagnosis and monitoring of hypertension. Allow me to please present acknowledgement for all the participating institutes in Africa and in Asia, and also the WHO colleagues, and also for the funding obtained from the Bill and Melinda Gates Foundation that enabled this work. That marks the end of my presentation.
Thank you so much, Dr. Molel, for sharing with us on a smartphone application for blood pressure estimation. For all the speakers who have already spoken, if you don't mind, please come sit on the front. And now, may I welcome the third presenter for the day, Doreen D. Smart. Doreen Smart will be sharing with us a talk titled My Tribe, an online interaction application for people with chronic health conditions. Welcome, Doreen.
Good afternoon. My name is Doreen Smart, and I'm an intern medical doctor. And today let's talk about my tribe. So imagine a digital space where chronic conditions do not define you, but instead they connect you. The prevalence of NCDs in Tanzania and other developing countries is rising, and non-communicable diseases among other chronic diseases are challenging to manage. The diagnosis period of tests and investigations, the treatment follow-ups can be stressful and lead to feelings of isolation and loneliness, which can lead to mental health problems such as depression. In fact, it seems that people with chronic health conditions are 2 times more likely to develop depression. And the Sustainable Development Goal 3.4 aims to reduce NCD-related deaths, but also improve the mental health mental well-being of these individuals. The world is currently moving more towards the digital landscape, and as the physical limitation may hinder the traditional in-person gatherings or meetings, it is concerning of how then will individuals with chronic health conditions find meaningful connections and support. This is an example of what they will opt for. This is simply a screenshot of WhatsApp group created kutoa ushauri wa matibabu na tiba kwa watu wenye magonjwa sugu. And there are members in this group. And we can see, for instance, one of the members complaining of being added without their consent. So these groups exist, but are they sufficient enough? And is the information being provided accurate? Who monitors or moderates this information in these groups? And are people who really need support get easy access to these groups? And also, are people who are being added with their consent? So I propose a mHealth interaction application, which is specifically designed for people who are living with chronic health conditions. And in here, these people will be able to connect with others who share similar experiences or understand what they are going through. Okay, so they will share personal stories and experiences, coping mechanisms, lifestyle modification tips, and support or resources and so forth. So we want to utilize this application also to raise awareness by giving accurate and reliable information to these people with chronic health conditions and reduce stigma. So with all this, we want to empower this person who has been diagnosed with the health conditions to be able to take charge in his own health and be able to navigate through the chronic health management with confidence and resilience. So in short, we want to transform the chronic disease management from a solitary struggle into a shared journey. So why my tribe? Just like the Haya maybe, or the Chaga or the Sukuma are united with each other or collaborate in various issues, we want to portray this sense of belongingness for these people who have chronic health conditions, and not merely defining them as a hypertensive patient or diabetic patient. We want them to use this to move together in the journey of managing their chronic health conditions. So we want to impact that sense of belongingness. The chronic health conditions seem to be having a rising trend, just like the global trends of chronic health conditions. But also, the internet access in Tanzania is also increasing. For instance, last year we had 15 million internet users, and this year we have in the beginning of this year we had 21 million internet users, which indicates a growing potential for digital health interventions. So we plan to include anyone who has been diagnosed with the chronic health conditions, who, as long as they are above 18 years of age. And we have decided to add other chronic conditions such as HIV/AIDS, even though it's not a non-communicable disease, because of its high significance and relevance in our setting. So let's take peek or a view at the demonstration of the application. It will be a mobile application called My Tribe, and this is a welcoming page. and the login page. And if you have no account, you can sign up, and the user can fill their credentials with the username of their own choice for the purpose of privacy and comfortability. And while signing up, there's an option of saying whether you are joining as the patient yourself or as the caregiver for personalization and customization purpose of the content for this user. So once you sign up, you'll see a page asking to select your tribe being the chronic disease that you have been diagnosed with. And you can view the profile page of the user, which will indicate his or her tribes, and there's an option of changing visibility, whether you want to share that information with the community or leave it personal. We'll have the insight, there's a feature of editing the tribes in case you have been diagnosed with the new disease, for example. So we have the insights section, where we'll be posting educational content or resources such as articles or video clips to raise awareness on NCDs. So one can search concerning any disease which she or he has selected, or in the page with all other diseases. So this is an example of an article where a user can read and earn awareness. So we have this section, community section, we call it a community section, whereby, for instance, we can see Kigamboni Diabetes Community, for example. So these communities will work as support groups, online support groups, but which will be created by us, the application runners, and in collaboration with, we aim to start with a few hospitals first, whereby the content in these communities or support groups will be highly monitored and moderated. So in here, they can ask questions to the fellow support group members or to a health personnel, because each group will have preferably a medical doctor to address those issues. They can discuss on medication adherence and various other issues. So yes, and we'll have a feature of, this is an example of conversation. We'll have a feature of groups which will differ from the community. These groups will be created by the users themselves. Okay, they'll join groups with other members to discuss everything or all matters, starting from health matters, their health matters, if they share the same disease or not, and even other matters, for instance, football or anything. It will be a place for them to interact, but as members who share the same disease or maybe attending the same clinic and so forth. So a new user will have an ability to search for a group. For instance, I have been diagnosed with hypertension and at Mbezi, so I can search hypertension Mbezi, and the group can, the app can recommend the groups which I'm supposed to be joining. Yes. So we have another feature of private messaging, where one can private message a medical personnel or a fellow support group member if they want to have their private conversation. So you can see this an illustration of a conversation between two users of the application. So that is a summary of the application, and we plan to have a comprehensive moderation policy which will clearly define prohibited content. We'll be against abusive language, harassment, false information, bullying, and so forth. There will be regular evaluation of this application to assess the effectiveness, if it's meeting, achieving its targets and goals. So we'll use metrics such as user satisfaction, or the number of support groups created, or the progress or outcomes of patients who are the application users and non-application users, depending on their diseases. Privacy, safety, and confidentiality of the users will be of utmost importance, safeguarding them against abuse and harassment, of course, and leaking of the information. And we expect any smartphone, iOS or Android, and it will also be web-based version. How do we expect the platform to sustain itself? So we aim to have, we plan to have sponsorships partnering with brands which will be interested in sponsoring it and featuring their products or services in the platform, but also selling advertising spaces for companies that target people with chronic health conditions as their primary consumers. So for instance, pharmaceutical companies, polyclinics, gyms for lifestyle modifications, people sell supplements and so forth. We can also have affiliate marketing whereby for each product sold or services sold, the application or platform will earn a commission. We can also have premium features where a user will have to pay for instance, exclusive content or medication counters or reminders and so forth. Currently, we are at a stage of the technical development of the application, and we are yet to test it by February 2024. We want also to train and orient a small group of users. We want to work with one or two hospitals at first, which we haven't decided yet, and launch it hopefully by May and July 2024. So we want to use the platform to gain data and capture the issues in the platform. We can collect data, analyze and report it, and also use the data obtained for advocacy, action and change. So we want to keep monitoring and evaluating the application and eventually scaling up. So why not the existing social media platforms? People with chronic health conditions also have Instagram accounts, WhatsApp accounts, Facebook accounts, and so forth. But these applications, like I said, lack specific features or tailored content for this population. And they can have difficulty in navigating through all the content and accessing the content that they need, which is concerning their chronic disease condition. And also the information available, it's not moderated. So this would be the first interaction platform in Tanzania, specifically designed for people who have chronic health conditions, which will be a unique advantage in the market. So we expect the budget to be about 20 million Tanzanian shillings, and this will cover infrastructure costs, and of course we need a team, for instance, of medical advisors, legal advisors, content creators, software designers, and so forth, marketing and promoting the application. So conclusively, I'd like to say that in a world full of fleeting trends and temporary trends and applications, let us build a lasting community for those who are enduring health challenges. So I call all of you to invest probably in ideas or opinions or anyhow to ensure that this groundbreaking platform is a success. Thank you.
Thank you so much, Dr. Doreen Smart, for sharing with us your Smart app. Without any further ado, may I welcome the fourth presenter for the day, Dr. Geoffrey Amos Segeza. Dr. Segeza will be sharing with us his talk on the role of digitalized health content approach in raising mental health awareness. Welcome, Dr. Segeza.
Good afternoon. My name is Geoffrey Amos Segeza, as I've been introduced. I'm from Afetun. Afetun, we are a group of medical personnel, including doctors, dentists, pharmacists, and lab scientists that are innovating around health information and its availability in the digital space. And today I would like to give a progress report of one of our products, that is through the animation series, through enlightening the role of digitalized health content approach in raising mental health awareness. So a highlight of Afetun. Afetun is a project that was founded in 2018, And this was a product of Mawazo Challenge that was under Human Development Innovation Fund. And since 2018, Afetun has had 2 phases. The first phase was from 2018 to 2021. That was a training phase for the team, because the team was made of medical students. And back in the time, we were all in med school, so we had a good time to learn about medical knowledge, having innovation and creativity knowledge through different challenges and innovation hub that we have been hosted to for the first 3 years, and then some of us started graduating. And since 2021, we have been practicing around digital health information, and also our solutions such as Rudy that I'm presenting today has been adapted by different organizations as the tool for medical health information. So currently, as I said, we're living in the era of information. Everyone, right in your hands or in your pocket, you have access to all kinds of information. 20 years back, to access this information, it had to take time. You had to go maybe sit, watch television, or have a time to tune into a radio. But currently, it's just 1 minute away for you to access any kind of information. And this is a good progress as a country, that we are increasing a number of internet users, but we still have a challenge. Are these information that we are accessing ready for normal users? I mean, people who are not in medical field to access, because as health information, as a health information field, we are facing a challenge of information overload and information that is not tailored to specific populations, and also most of our information platforms are one-way communication centered. And this is a challenge, because with this health information that we're giving the society, we need to make change and to help them to progress through different conditions. So we navigated through this as some other solution that we are developing, but we had this particular specific information and solution for mental health. Currently, in the worldwide statistics, we have around 1 billion, an estimation of 1 billion people who are affected by mental health conditions. And this is producing a lot of burden in the society and community that these people are residing, including disability and also long stay in the hospital. This also drags back into the economic burdens to these people, and then adjust them to the vicious cycle of poverty. But surprisingly, we have a challenge that we can solve altogether, because from research, one of the factors that are affecting these people and having this kind of burden in our communities is lack of health information that is appropriate. And as we speak right now, more than 70% of people who are suffering from mental health conditions are not accessing are not accessing treatment facilities, or are not having medical attention because of lack of proper information. And that's when that's what we are innovating for. We're innovating around health information and type of information that these people are receiving. So we have a solution. Our solution is based on storytelling, just like we see series, movies, songs, animations, and cartoons. We as Afetun, we are innovating around animations. We are producing animation series that are covering health stories, and we use storytelling techniques together with our animation studio that we have right now to produce animation series that will have health information in a simple, enjoyable language that anyone at any level of education, at any level of economy can access and have a benefit of it. This solution is based on storytelling, as I said, animation using 3D animations, comics, and also CGI, and computer-generated images, and also artificial intelligence. We're creating it through enhancing behavioral change that will lead into compacting NCDs and particularly mental health. This is how we do it. We start with human-centered design. This is, as I said earlier, we have a compact of medical information. We also go in the street and access the street language that people can understand easily, these medical terms, and also the perception. And then we go to co-creation of this content. Most of this content that we co-create with partners such as Ministry of Health. We also have done a work with Mirembe, National Mental Hospital, and all other associates that we're working with to create this content to make sure that it's appropriate to our facilities and it's appropriate to our context. Then after that, after our content is well fabricated, we go to first, that is production. And as I said, you use computer-generated images, artificial intelligence, and animation using 3D animations and comics to produce this. And then we go to the second phase, which is dissemination. In dissemination, we use local traditional media. Also, we use social media that we have and outreach programs. Then we create these programs to be self-sustaining because most of this content, we share them in websites, in social media, and this can be used. So far, this is our distribution strategy. As I said, we have online platforms. We have YouTube channel that we're sharing this mental health series. And we're also doing grassroots outreach programs. We have already done 3 outreach programs with this product that we have, that is Rudy Mental Health Series. And also we are doing media partnership currently. We're partnering with local media to showcase our content through televisions, because as I said, we're creating animations, and also through radio, because these animations have good audio that can be shared and people can grasp concepts. Also, we do that by training professionals such as journalists. We have a program to train journalists concerning mental health and dissemination of these products in a way that is well understandable. Currently, where we have already produced the one animation series containing 80 episodes, and it's about 20 minutes long animation series that is the first Swahili mental health series, and actually I think it's the first Swahili health content that is showcased in terms of art, and that is currently free, available on YouTube, and also we have been showcasing this in television. And our reach, we have created a reach, as I said, this is a sustainable project. We have created a reach of more than 40,000 young people that we reach on social media monthly, and we have already reached around 1,000 young people through outreach programs. The first one was launching that we did, and also we have showcased these contents in Swahili Hip Hop Festival, and also we showcased this content in Suicide Prevention Week in Dodoma. Currently, we are partnering with local and regional organizations through dissemination of this content, which is Rudy Mental Health Series. That is a mental health series, and we have been partnering with Ministry of Health during the Mental Health Month, and also we have a partnership with Mirembe National Mental Hospital and also AAPH through dissemination. We are disseminating this content at EATV radio, and also EATV and also EA radio. And currently we have a program to train our own team and also to train journalists concerning issues of mental health. So this is the future of the program that we're having. Currently, this is the current state. As I said, you have created one animation, mental health animation series, that is Rudy. And currently, we are in a development stage of an online consultation platform that will be hosting different people with mental health challenges. And this health platform will give advantage to people because we'll have all our contents that is concerning mental health and also NCD in general available at this platform. And on top of that, we'll have other features such as online consultation to doctors, and also online platform that these people will have to share their views. And as I said, it will be affordable, is accessible, and also it will provide privacy and anonymity for these people. So as I said earlier, that we all know that we are facing the issue of information challenge also were facing the issues of discrimination. So lastly, I would like to appreciate the work of this team that has been working together to make sure that we are producing this good work of Rudy Mental Health series. And thank you for listening.
Thank you very much, Dr. Segeza, for sharing with us on your digitalized health content approach. We are going to have the last presentation for the day. This is coming from Angela Masawe. Angela Masawe, she's a public health specialist, and she'll be sharing with us her talk on leveraging digital health to promote longitudinal care and patient outcomes for hypertension and diabetes in Tanzania, the Afya Imara program. Welcome, Angela.
Good day to everyone. My name is Angela Masawe. I'm the program operation lead working with Medtronic Labs Tanzania. But I would also like to acknowledge the presence of our implementing partner, the CSSC team. And I'll go straight to the topic for today, whereby we'll be talking about the leveraging digital health to improve longitudinal care and patient outcomes for the hypertension and diabetics in Tanzania. But I would like to take you through briefly of what Medtronic Labs are. So we are non-governmental organization, but what we really do is we design and implement tech-powered healthcare delivery models. So we work in strengthening health system, and we work with governments, local organizations, and so forth. So Afya Imara program had started last year, January. So we are about 1 year and 10 months now. So we have been implementing with FBOs, the faith-based organizations, and currently we are working with 21 facilities which are under CSSC. And the program was initiated in patient-centered models, and there are like 4 models that were used in this program. That is digital and product technology, field operation, patient engagement, and education to the patients. So what did we expect from this program? So one of our expectations was to improve the diagnosis of both conditions, that is diabetes and hypertension, adherence to treatment, the controls of all the patients that we're working with, but also improving the care to these facilities that we're working, and also trigger the behavior change. So as I said, we have been working with CSSC sites for the past 1 year and 10 months. And we had a founder, the founder was Sanofi Global Health, whereby they had finished the contract with us, which was in June. So currently, we are in sustainability phase. And as I said, there are 21 facilities which are situated in 4 regions in Tanzania, which are Dar es Salaam, Morogoro, Arusha, and Kilimanjaro, and working with all levels, as to say, from dispensary to zonal levels. So we are a tech design organization, and we have a digital platform which is called SPICE. So SPICE is an open source and interoperability. It's not only a data collection tool, but also a very good data-driven tool which links clients from the community to the healthcare facilities. So it has the community aspect, and there's, let's say, 3 models of SPICE, whereby we have the SPICE score, where it has the community aspect, empowering the community health workers in doing the screening in the community, whereby immediately when they identify a client who has elevated BP or BG, it directly gives a red alert to the doctor, to the specific facility that SPICE is there. So the client is needed to go and visit the doctor for confirmation before being enrolled into the program. So how do we do follow-ups? So we have the SPICE Engage. This is the workflow whereby it gives different components like lost to follow-up patients. It gives who to prioritize in calling. It gives you the red alerts like which patient needs quick attention, but it gives you the screening patient together with the enrolled patient and seeing who can be called and invited to the clinic. But we also have the SPICE Insight. So here, this dashboard, it gives the metrics, like all the data that is entered into the SPICE, and it's not only useful for the healthcare providers, but also the hospital management to mobilize resources, to know which medication is being used by the patients, and things like that. So as I said, we do follow-ups, not only enrolling the patients, but we do follow-ups. There are different ways where we do follow-ups. For example, the SPICE. Excuse me. I think there's something wrong with the presentation. Please allow me to continue. So AFIMARA program have had different components which made it to a success in improving hypertension and diabetic cases, follow-ups, and controls. One of it is the tech-enabled solution whereby we did screening, referrals, and follow-ups, but also facility-led community outreaches, whereby the facilities were able to conduct outreaches in seeking the hypertension patient together with the diabetic patients, but also the teleconsultation, whereby our team together with the hospital team were able to call and prioritize the lost to follow-up patients. But also we were able to empower the healthcare providers together with the community health workers through training for the digital tool to improve efficiency, effectiveness, and the quality of care in the facilities. But also we took them through on the training for the NCD guidelines, the SOPs for both the healthcare providers and the CHWs. But also the data utilization, whereby the SPICE Insight, it gives us data and improve, especially for the hospital management. This was very, very useful in making decision making. So throughout our program, we were able to do targeted screening, and whereby we were able to screen 73,115 patients, but get enrolled of about 18,742 patients. Throughout the program, we were able to have a control of hypertension patients at 63% versus 19% at baseline. For the diabetic patients, at control of 76% versus 46% at baseline. So throughout our program, we have lessons learned, and we'll start with the health system strengthening, and whereby we were able to achieve the controls of both patients, the hypertension patient together with the diabetic patient. At least 60% of the patients enrolled had achieved control. But also the community-driven initiatives, empowering the healthcare providers in conducting the outreaches, seeking patients who have this condition and linking them to care. But also, currently we are having the sustainability approach. We are making it, we are empowering the healthcare, as in the facilities that we are working with, to use the use of intensively the clinics, making follow-up for the defaulters, and also the capacity building of healthcare system users. But with the digital technology, leveraging on real-time data, because SPICE gives us real-time data. As soon as the patient gets screened or enrolled, the data reflects on the dashboard. But the SPICE platform is also user-friendly, and it gives, it's easy to use, but also the catalytic support of the health facilities with the devices and phones into using the digital platform. When it comes to partnership, we have been engaging with MOH, trying to leverage our outcomes and seeking on scaling this to public sites, but also working with the local organizations, trying to seek and how can we take these initiatives to other facilities, but also working with healthcare workers, the facility managers, together with the community health workers, whereby we onboarded and support to deliver quality NCD care while leveraging on the digital platform. So our recommendation is, so after implementation, or as we continue implementing this program, we have seen it's scalable. We can scale it up it's scalable with the digital health tool model at both community and facility level, has the potential of accelerating progress towards national and global NCD targets. But also the model should also be tested with other settings, and this is whereby we welcome any organization who seeks to work with us, public sectors, and other NCD and other, it can be modified into other diseases of public health interests in the country. So thank you for listening. Thank you for listening.
Thank you very much, Angela, for sharing your talk. Now, with great honor, may I welcome the audience for questions, comments. We have heard from our presenters. Now I welcome you for comments and questions. So if you have any question, may you please raise up your hand. There are no questions? The sessions were all clear or they're all confusing? Please share the microphone to Dr. Mary.
Thank you. My name is Dr. Mary Maige. I come from the National Institute for Medical Research. I first would like to congratulate all the presenters. I think we've had some wonderful things and we see the digital transformation in healthcare. My question goes to, I think I would like to know from all the presenters, because this is electronic information, I would like to know where most of it, where the data is hosted and whether it is all in conformity with our data regulations, in-country regulations, because if we're interested to extend the use of those nice platforms, we also have to have a basic understanding of how the data is being captured, how is it stored. But a specific question to Dr. Angela, I've seen that you have tremendous improvements in the outcomes of your diabetic and your hypertensive patients, and I think that's very impressive. And I wanted to know, what do you think contributed to that, and whether all the patients that you enroll, do you give them medicines, or they have, because we know we have issues with accessibility. So what do you attribute that success to? I would like to hear some comments from you. Thank you.
Thank you so much, Dr. Mary. So, because the second question is specific to Angela, may I welcome Angela? Angela, please respond to Dr. Mary Maige's question.
Dr. Mary, can you please repeat? I didn't get you clearly.
So the first one was a comment, a congratulations to you all. So I hope that's very clear. The second one was with regard to hosting of the data, because you, in your presentation, most of you welcomed us to use your platforms, but I just wanted to know whether, where exactly is your data hosted? Is it in country? Is it in the cloud? And how does it conform to the local regulations? And the third one was with regards to the outcome of your patients, because I saw that you had an improvement from, like, I don't know, 18%, 16% to over 60-something% in control, in terms of the outcomes of your diabetes and hypertensive patients. So I was just wondering what contributed to that, because if we look at most of the outcome data that we have from our programs, most of our programs, we don't get that high percent of patients being controlled. So I just wanted to know what led to your success. Thank you.
Thank you, Dr. Mary. I'll start with your first question. For the data hosting, currently we are at AWS, Amazon, but we are working in storing the data in NIDC. So in the near future, the data will be hosted in country. For the second question, what led to the great improvement of the controls of our patients? So one of the things which led to a great improvement, I would say, first of all, is the use of the tool for tracking lost to follow-up, the defaulters, which is Spice Engage. So it gives us various components to prioritize who to call and come back for the clinics, but also the use of CHWs who went to door in doing assessment. But also, it was one of the great, let's say, it was one of the great survey that we also wanted to know, like, especially for the diabetic patients, like what really, what contributed to such a great control. So we did a small survey with all facilities that we work with. One of the things that came up highly is the investment of health education. So it happens, most of our patients knew when to take their medicine, the diet, we conducted to know how do they know the size, what are they supposed to eat, what time, so stuff like that really had contributed to such a great output. Thank you.
Okay, thank you so much, Angela. May you pass the mic to Geoffrey. May you respond to Dr. Mary's questions on how you guys conform to the local regulation in running the apps and the materials, right, Dr. Mary? Yeah. Welcome, Geoffrey.
Okay, thank you, Dr. Mary, for this nice question. At AFETUN, we have a policy of we have two ways of data authentication. So the first one is we offer anonymity for the platform that we're creating, that anyone that is subscribing to our platform doesn't have to fill the actual information because of the ongoing issues of stigma concerning mental health in our country. And then the second way is how we store our data. So currently we still have a challenge with local servers, but that's the way forward in the coming year, so as to have full monitoring of the data that we are going to store. And it's because we have also not yet launched the application for public use. But once we start the public use of the application, we'll have local data servers and full control of the data. Thank you.
Okay. Thank you so much. Doreen, you love to say something? Welcome.
So thank you for the question. And for the application, My Tribe, we will ensure, we are planning to ensure the privacy of the information of the patient with the first feature of having the username and credentials of the patient as their own choice if they want to have their real names and information posted or shared with the community or not. And we are still in the technical development of application, so we are still working on deciding on which technical companies to work with, which can provide us with the servers or the databases for storing our data that will be obtained from the application.
Okay. Dr. Moller?
Thank you very much, Dr. Mary, for the question. So for the OptiBP study, each participating country, Tanzania, Bangladesh, and South Africa, each country has access to the in-country data and not the data from across. And because the study was centrally controlled by the WHO, we've all signed the data sharing agreement from NIMRI with the WHO offices in Geneva for the collective data. And also the developers of the OptiBP app did not have access to the data and did not even participate in the analysis. And also there was an independent data analysis board just to make sure that the validation of the OptiBP app was ethical without any biases as to making it seem as a valid app for BP measurement.
Okay. Yes, Dr. Mary, thank you for your question. I presented a feasibility study of remote patient monitoring using Muhimbili and the fact that it could be applicable in other parts of the country. And actually, this was one of the requirements of e-government when we consulted them regarding this technology that we would like to use at our facility. The requirement was that the data has to be hosted within the country because at the moment it's hosted in the cloud. And luckily the company has that option, and they have agreed to our recommendation that if at all we have to use it at full scale after the pilot, then it has to be local hosted data and with full ownership to the institution. Thank you.
Okay, thank you very much to our presenters. I'm told we're supposed to end at 15:55 and it is 15:55. Thank you so much to our presenters for sharing your talk. It was really nice to have you all, and thank you all for coming and for being attentive audience. Thank you. Now we adjourn our session.
Profesa Polinari Kamuhabwa ni kaimu makamu mkuu wa Chuo Kikuu cha Afya na Sayansi Shirikishi Muhimbili. Ninapenda kutoa taarifa kwa umma kwamba chuo chetu cha Muhimbili mwaka huu kimetimiza miaka 60. Chuo chetu kilianza mwaka 1963, leo hii 2023 tumetimiza miaka 60. Kwa hiyo tunaandaa shughuli ambayo ni symposium tarehe 16 ambayo itakuwa siku ya Alhamisi mwezi wa 11 2023 kwa ajili ya kumbukizi ya miaka 60 chuo chetu. Kwa hiyo tutakuwa na mdahalo wa kuangalia tumetoka wapi, tuko wapi, nataka chuo chetu kiende wapi. Kwa hiyo tumealika wadau mbalimbali, wahitimu wa chuo hiki, watumishi wa mbalimbali, mashirika mbalimbali. Tunakaribisha sana mje siku hiyo tarehe 16 Novemba, mshiriki na sisi tutakuwa na mdahalo mzuri, lakini vile siku hiyo mchana tunakuwa na mkutano wa mwaka wa alumni, wale watu wote waliosoma Muhimbili. Lakini kumbukizi hii chuo chetu tutamalizia siku ya tarehe 18 ambayo itakuwa Jumamosi. Tutakuwa na shughuli ya kukimbia, kutembea, wanaita fun run. Kwa hiyo mnakaribishwa sana siku hiyo ya Jumamosi, tusherekee matunda ya chuo chetu kutimiza miaka 60. Karibuni sana.
Naitwa Profesa Bruno Sunguya, ni naibu kaimu makamu mkuu wa chuo, utafiti na ushauri. ningependa kuwakaribisha nyote katika siku ya tarehe 16 mwezi Novemba mwaka 2023 ambapo tunakwenda kuadhimisha maadhimisho miaka 60 tangu kuanzishwa kwa chuo chetu cha Afya na Sayansi Shirikishi Muhimbili. Katika maadhimisho haya tutakuwa na kongamano kubwa ambalo litahusisha wadau mbalimbali kujadili historia tulipotoka na tunapotaka kuelekea katika miaka mingine 100 ya chuo chetu. Sambamba na maadhimisho haya kutakuwa pia na maonesho mbalimbali ambapo tutakuwa tuna huduma za afya bure kwa wananchi kama sehemu ya kutoa mchango wetu kwa wananchi katika masuala mbalimbali ya afya. Lakini vile vile kutakuwa kuna maonesho ya tafiti na mazao mbalimbali ya tafiti zinazofanyika katika Chuo Kikuu cha Muhimbili. Tunawakaribisha nyote tujumuike pamoja kuweza kusherehekea miaka 60 ya uwepo wa Chuo Kikuu cha Afya na Sayansi Shirikishi Muhimbili. Asanteni sana. Naitwa Profesa Bruno Sunguya, ni naibu kaimu makamu mkuu wa chuo, utafiti na ushauri. Ningependa kuwakaribisha nyote katika siku ya tarehe 16 mwezi Novemba mwaka 2023 ambapo tunakwenda kuadhimisha maadhimisho miaka 60 tangu kuanzishwa kwa chuo chetu cha Afya na Sayansi Shirikishi Muhimbili. Katika maadhimisho haya tutakuwa na kongamano kubwa ambalo litahusisha wadau mbalimbali kujadili historia tulipotoka na tunapotaka kuelekea katika miaka mingine 100 ya chuo chetu. Sambamba na maadhimisho haya itakuwa pia na maonesho wa chuo, utafiti na ushauri. Tuna huduma. Ningependa kuwakaribisha nyote katika siku ya tarehe 16 mwezi Novemba mwaka 2023 ambapo tunakwenda kuadhimisha maadhimisho miaka 60 na mazao mbalimbali ya kuanzishwa kwa chuo chetu cha Afya na Sayansi Shirikishi Muhimbili. Tunawakaribisha nyote. Katika maadhimisho haya tutakuwa na kongamano kubwa ambalo litahusisha wadau mbalimbali kujadili historia tulipotoka na tunapotaka kuelekea katika miaka mingine 100 ya chuo chetu. Sambamba na maadhimisho haya kutakuwa pia na maonesho mbalimbali ambapo tutakuwa tuna huduma za afya bure kwa wananchi kama sehemu ya kutoa mchango wetu kwa wananchi katika masuala mbalimbali ya afya. Lakini vile vile kutakuwa kuna maonesho ya tafiti na mazao mbalimbali ya tafiti zinazofanyika katika chuo kikuu cha Muhimbili. Tunawakaribisha nyote tujumuike pamoja kuweza kusherehekea miaka 60 ya uwepo wa chuo kikuu cha Afya na Sayansi Shirikishi Muhimbili. Asanteni sana. Naitwa Profesa Bruno Sunguya, ni naibu kaimu makamu mkuu wa chuo, utafiti na ushauri. Ningependa kuwakaribisha nyote katika siku ya tarehe 16 mwezi Novemba mwaka 2023 ambapo tunakwenda kuadhimisha maadhimisho miaka 60 tangu kuanzishwa kwa chuo chetu cha Afya na Sayansi Shirikishi Muhimbili. Katika maadhimisho haya tutakuwa na kongamano kubwa ambalo litahusisha wadau mbalimbali kujadili historia tulipotoka na tunapotaka kuelekea katika miaka mingine 100 ya chuo chetu. Sambamba na maadhimisho haya kutakuwa pia na maonesho mbalimbali ambapo tutakuwa tuna huduma za afya bure kwa wananchi kama sehemu ya kutoa mchango wetu kwa wananchi katika masuala mbalimbali ya afya. Lakini vile vile kutakuwa kuna maonesho ya tafiti na mazao mbalimbali ya tafiti zinazofanyika katika chuo kikuu cha Muhimbili. Tunawakaribisha nyote tujumuike pamoja kuweza kusherehekea miaka 60 ya uwepo wa chuo kikuu cha Afya na Sayansi Shirikishi Muhimbili. Asanteni sana. Naitwa Profesa Bruno Sunguya, ni naibu kaimu makamu mkuu wa chuo, utafiti na ushauri. Ningependa kuwakaribisha nyote katika siku ya tarehe 16 mwezi Novemba mwaka 2023 ambapo tunakwenda kuadhimisha maadhimisho miaka 60 tangu kuanzishwa kwa chuo chetu cha Afya na Sayansi Shirikishi Muhimbili. Katika maadhimisho haya tutakuwa na kongamano kubwa ambalo litahusisha wadau mbalimbali kujadili historia tulipotoka na tunapotaka kuelekea katika miaka mingine 100 ya chuo chetu. Sambamba na maadhimisho haya kutakuwa pia na maonesho mbalimbali ambapo tutakuwa tuna huduma za afya bure kwa wananchi kama sehemu ya kutoa mchango wetu kwa wananchi katika masuala mbalimbali ya afya. Lakini vile vile kutakuwa kuna maonesho ya tafiti na mazao mbalimbali ya tafiti zinazofanyika katika chuo kikuu cha Muhimbili. Tunawakaribisha nyote tujumuike pamoja kuweza kusherehekea miaka 60 ya uwepo wa chuo kikuu cha Afya na Sayansi Shirikishi Muhimbili. Asanteni sana. Naitwa Profesa Bruno Sunguya, ni naibu kaimu makamu mkuu wa chuo, utafiti na ushauri. Ningependa kuwakaribisha nyote katika siku ya tarehe 16 mwezi Novemba mwaka 2023 ambapo tunakwenda kuadhimisha maadhimisho miaka 60 tangu kuanzishwa kwa chuo chetu cha Afya na Sayansi Shirikishi Muhimbili. Katika maadhimisho haya tutakuwa na kongamano kubwa ambalo litahusisha wadau mbalimbali kujadili historia tulipotoka na tunapotaka kuelekea katika miaka mingine 100 ya chuo chetu. Sambamba na maadhimisho haya kutakuwa pia na maonesho mbalimbali ambapo tutakuwa tuna huduma za afya bure kwa wananchi kama sehemu ya kutoa mchango wetu kwa wananchi katika masuala mbalimbali ya afya. Lakini vile vile kutakuwa kuna maonesho ya tafiti na mazao mbalimbali ya tafiti zinazofanyika katika Chuo Kikuu cha Muhimbili. Tunawakaribisha nyote tujumuike pamoja kuweza kusherehekea miaka 60 ya uwepo wa Chuo Kikuu cha Afya na Sayansi Shirikishi Muhimbili. Asanteni sana. Naitwa Profesa Bruno Sunguya, ni naibu kaimu makamu mkuu wa chuo, utafiti na ushauri. Ningependa kuwakaribisha nyote katika siku ya tarehe 16 mwezi Novemba mwaka 2023 ambapo tunakwenda kuadhimisha maadhimisho miaka 60 tangu kuanzishwa kwa chuo chetu cha Afya na Sayansi Shirikishi Muhimbili. Katika maadhimisho haya tutakuwa na kongamano kubwa ambalo litahusisha wadau mbalimbali kujadili historia tulipotoka na tunapotaka kuelekea katika miaka mingine 100 ya chuo chetu. Sambamba na maadhimisho haya kutakuwa pia na maonesho mbalimbali ambapo tutakuwa tuna huduma za afya bure kwa wananchi kama sehemu ya kutoa mchango wetu kwa wananchi katika masuala mbalimbali ya afya. Lakini vile vile kutakuwa kuna maonesho ya tafiti na mazao mbalimbali ya tafiti zinazofanyika katika Chuo Kikuu cha Muhimbili. Tunawakaribisha nyote.
Good afternoon, everyone. Thank you very much for being here in our closing session. We are waiting for the guest of honor who will be here in 2 or 3 minutes. In just a few minutes, he will be here and we'll start. So I will ask you to be just a little bit patient. It won't even get to 5 minutes. So please be patient so that we close together. Thank you. Good afternoon once again. If you really do not mind, I will ask you to just move forward a little bit so that we are at least all in front. If it's not too much trouble, I will request you just to move a little bit forward so that we are all here at the front. But if you think it's too much trouble, you can just stay.
utakuwepo kesho. Yote nilofanya kwa taifa langu yatachukua na kuonekana tena. Naisikia moyoni raha ya upendo huu iliyonizunguka kwa ndani ya moyo wangu, kwa sababu bendera itaendelea kupepea kwa uhuru, kwa sababu bendera itaendelea kupepea kwa uhuru. Undugu na umoja wetu ni mikono iliyotushika, inatuongezea thamani kwa majirani waliotuzunguka.
Naisikia rohoni raha ya upendo huu
kwa sababu bendera itaendelea kupepea kwa uhuru,
kwa sababu bendera itaendelea kupepea kwa
Our guests of honor has already arrived. We can all stand up as they go in, as they coming in. We can all stand up. Thank you very much. Thank you. We can all sit down. Asanteni sana. Our guest of honor, the Permanent Secretary, Ministry of Health. Thank you so much for honoring us in this closing ceremony of the Regional NCD Scientific Conference. We are honored to have you here with us. We had a very fruitful 3 days, and I am sure you have heard about it. And all the dignitary on the high table and the participants, good evening once again. Now, without wasting much time, I'd like to welcome Dr. Omari Buguyu, and he will come and give introduction of participants before we continue, and our dignitary in the high table. Karibu sana.
Okay, good afternoon, ladies and gentlemen. Dr. John Jingu, Permanent Secretary from the Ministry of Health, and the guests of honor. May I introduce to you a list of participants who are here with us today. starting with Professor Bruno Sunguya, representing Vice Chancellor from MUAS, and is also a chairperson of this 5th National NCD Conference, together with Dr. Professor Bruno. Please stand up, at least. Okay, together with Professor Sunguya is Dr. Mary Maige, who is representing Director General from NIMRI and is a co-chairperson of this conference. With you here today is Dr. Nicholas Kamara. He's a member of parliament from Uganda and is also a member of NCD Party Caucus as part of the MP group within Uganda parliamentary group. So thank you. We have Professor Pascal Lugajo, who is the Director of Curative Services, and he's the man behind all the machineries for this because it is coming from his section. Yes, we have Professor Joseph Mukumbis. He's a President of East African NCD Alliance. He is representing other NCD Alliance, including Tanzania NCD Alliance, which is represented today. We have Uganda NCD Alliance. We have Rwanda NCD Alliance, Kenya NCD Alliance, and we had colleagues who were online, and these were from Nigeria and other countries. We also had Danish NCD Alliance with us. So, Professor Mukumbus, thank you very much for organizing and collaborating with us. Then we have Meds Moons, representing World Diabetes Foundation. Just in a nutshell, WDF were the champion behind this success. They are the ones who supported us from the beginning, and we hope they continue supporting us. Then we have Professor Kaushik and Professor Swai. These two old men, they are always young because of their support on NCD. Please, Professor Swai and Kaushik, stand for them. We have leaders from regional administration, local authority. We have colleagues from the Ministry of Health. We have heads or representatives of heads of institutions from hospitals and health institutions in the country. We have representatives from non-state actors. We have representatives of industry and other colleagues who are here with us again. We have students who are always the part of this conference. We want to train them. And we have distinguished guests, members of media, gentlemen. Thank you very much for being with us. And let me hand over my MC the other delegation. Karibu.
Thank you so much. That is Dr. Mary Guyo, who is the Assistant Director of Non-communicable Diseases under the Ministry of Health. Now, without wasting much time, I'd like to welcome the Acting Vice Chancellor of the University of Health and High Science, Professor Bruno Sunguya, who will come and make a welcoming remark together with the recommendations of this conference. Karibu sana.
Jamhuri ya Muungano wa Tanzania. Tumechoka. Jamhuri ya Muungano wa Tanzania. Good afternoon, everyone. Your Excellency, Guest of Honor, Permanent Secretary, Ministry of Health, Dr. John Jingu, Dr. Mary Maige, the co-chair, and also representing Director General NIMBRI, Dr. Nicholas Kamara, MP from Uganda, but also representing NCD Parliamentary Caucus from Uganda, Professor Pascal Rugajo, Director, Curative Services, Professor Joseph Mukumbitsi, President of East Africa NCD Alliance, Mets Moods from WDF, Professor Kaushik and Professor Swai, our mentors, but also the champions of the work that we do today. Dr. Omari Ubuguyu, Assistant Director, NCDs, ladies and gentlemen, my fellow scientists, media, students, and colleagues present here today. I'm really honored to stand before you after 3 days of heavy science, presentations, and abstracts that have been presented that have really shown how the country and the region is moving towards the fight of non-communicable diseases in all fronts, from the prevention side, from the curative side to the rehabilitation side, and every other sector that is involved in the fight. Guest of honor, for the past 3 days, we have been convening here. During the first day and the second, we have been having a total of close to 700 delegates from various walks of life, from various institutions, but importantly, this year, in a special way, from outside the borders of Tanzania. You have been informed that we have been having delegates from Rwanda, from Uganda, from Kenya, from Burundi, and other places that we have been working together. But this work has a history, guest of honor, and may I just tell you a few sentences out of it. We started this journey about 5 years ago, and the first national non-communicable diseases was conducted in Dodoma. And after that, we conducted the second one. In the first one, the Honorable Prime Minister made it official that every second week of November we'll be commemorating the NCD week. And through those directives, we have been conducting not only the scientific events, but also the activities towards the fight of non-communicable diseases, including working with the students, strengthening their capacity, some of the physical activities, but also advocacy and screening of non-communicable diseases that will soon also start, I think, next week or so. Guest of honor, the second event was conducted about 4 years ago in this venue, and the third one we conducted it in Arusha. The fourth one we conducted it in Mwanza, and this is the fifth one. And with the directives of your office and the Ministry of Health, they thought that now we are maturing and therefore we need to go regional. And because of the collaborations that we had and the partnerships that we had, we thought it is important to include other countries that we are bordering with, because diseases knows no border. What we have here is equally affecting other places. We can also learn from one another. Honorable guest of honor, I would also wish, before I present to you the recommendations of this conference, I wish to also sincere thank the following. WDF has been working with us for all these 5 years, financially, and also giving us the technical assistance. We thank you for your support. We also thank Ministry of Health for stewardship, but also for being with us hand on hand, making sure that these events are happening financially, morally, but also technically. Colleagues from Ministry of Health have been vital to the occurrence and